Hi, everyone, and welcome to today's discussion on how to choose clinically relevant targets for infectious disease panels, sponsored by Thermo Fisher Scientific. Representing Thermo Fisher, I am Rebecca Shore, your moderator, for about the next hour or so. I have a background specifically in epidemiology and biostatistics, and within Thermo Fisher, I lead our health economics and outcomes research and reimbursement strategy for the genetic testing solutions business unit. With the changes in health policy and policies over the last about 12 to 24 months, referencing specifically infectious disease syndromic panels, PCR testing for infectious agents, or more broadly, molecular diagnostics or specified policy, our customers have surely been grappling with how to choose content that belongs on panels and is ultimately clinically relevant. Today, I am excited to share this time and facilitate the discussion between Marcus Cognetti of P4 Diagnostics and Dr. Ari Frenkel of Arkstone Medical Solutions. For the first portion of today's webinar, we will have a discussion between Dr. Frenkel and Marcus around the considerations for panel content. And around the 45-minute mark in the last 15 minutes, we'll have a live Q&A where we will take audience questions and have our experts answer. At the conclusion of this webinar, we hope you have a better understanding of the learning objectives outlined for this webinar, which include reviewing existing published content, whether that's literature or guidelines that are existing to choose your panel makeup. We hope you understand what clinical evidence requirements exist and how to navigate them. We hope you walk away with a better understanding of how to select relevant organisms and antimicrobial resistant gene targets. And we'll sprinkle in some reimbursement and policy considerations as we move through these questions and answers. With that, let's have Marcus introduce himself.
Thank you, Rebecca. I appreciate the opportunity and look forward to the discussions with Dr. Frenkel and yourself today. So I'm Marcus Cognetti. I'm one of the founders of P4 Diagnostics. P4 is a national network of laboratories. We currently have 10 labs across the United States. 2 of our labs today do our molecular testing in New Jersey and in Indianapolis, and we're adding a 3rd facility for molecular testing this summer, and excited about that. So we've been involved in syndromic testing since we started our gastropathogen panel back in 2017. We launched our first version of our UTI assay in 2018, and we got into respiratory testing in 2019, just before the pandemic. Obviously, got heavily involved with COVID testing during the pandemic, and basically offer anatomic pathology, clinical pathology, and molecular pathology services throughout the country. Our lab in Indianapolis is our next-gen sequencing experts, and they've actually been doing PCR for a decade before the core P4 labs joined. So excited to have this conversation today and looking forward to the discussion.
Amazing. Marcus, thank you for that introduction. And P4 is clearly an impressive laboratory, and your expertise is going to be extremely appreciated during this. Dr. Frenkel, would you like to introduce yourself and Arkstone Medical Solutions?
Sure. Thank you. It's a pleasure to meet everyone. My name is Ari Frenkel. I'm a physician specialized in infectious disease and epidemiology. I'm the co-founder and chief science officer of Arkstone. Arkstone provides laboratories with antimicrobial stewardship and in many respects the gold standard of lab reporting solutions using artificial intelligence to bring infectious disease expertise in real time with every single infectious disease lab result. So glad to be here as well, and looking forward to our discussion.
Dr. Frenkel, thank you for the introduction, and we're excited to have your remarkable and notable expertise today as well. As I alluded to before, our customers need to contend with the content selection for panels, and that's the entire reason that we're at this webinar and in attendance today. So, Marcus, with P4, would you care to discuss where commercial labs are choosing their content and how they're choosing it?
Yeah, absolutely. And it's a great inflection point right now with the public health emergency having ended. I think many of us have seen this over the last year as COVID volumes have gone down. There were labs like P4 that were in infectious disease and molecular testing beforehand, but there's many others afterwards that had spun up testing for COVID and are now looking or have been looking for new ways to utilize those testing platforms. So the first recommendation and guidance that I've got in terms of choosing content is looking at who your customer base is. At P4, we're very heavily into urology, gastroenterology, OBGYN. And so you pick markers and you pick panels that you're trying to address a specific need, but also tailoring those towards the clients that you have. Everything runs the gamut from FDA labeled tests. You have that in gastroenterology, you have that in respiratory, to LDT assays. And so you can look at towards existing tests as guidance on where to start as you look to address specific needs within specific patient populations. One of the things, and I know Dr. Frenkel and I have talked a little bit about this, and I'm sure, Rebecca, you would agree with this, is when you're looking to design an LDT test, there's examples that maybe are a little bit suboptimal. You don't look at CPT coding for this. You need to consider what reimbursement is when designing a test, but you don't want to go through like a CMS checkbook and look at what are reimbursable. Design the test based off medical efficacy and understanding what the reimbursement landscape is going to be with your providers, but then design it towards the best outcome in terms of what that test result will look like.
Yeah, I think what you're saying is tailoring to the client, and the client in your case would be a physician. And as we have Dr. Frenkel here, I think, Dr. Frenkel, do you have any input on how the labs may tailor from their content to the infectious disease physician, or your putting on your public health epidemiology hat?
Yeah, I would like to add to what Marcus already said, that many times laboratories will start with ready-made panels. So they'll look at some of the manufacturers who have these panels already made. And most labs find that as a great place to start when they're building their molecular panels. However, labs also look to their peers and they look at their competition for ways to improve and build upon that. So we typically see the starting point is the path of least resistance, what's already available and easy to find. And then from there, typically labs start to expand their offerings to their clinicians and add more customized targets for both microbes and resistance.
Yeah, I think the expansion with the content selection is extremely important. And Dr. Frenkel, would you expand on the scientific literature that exists, maybe guidelines that aid in the content selection process? And can you describe the thought process and maybe what gaps or lags are present with regard to infectious disease panels, specifically within the US?
Yeah, sure. There is actually a lot of data regarding the use of molecular diagnostics, including its use for rapid diagnostics in the setting of sepsis or diagnostics of STDs or certain microbes, and how to use the resistant gene data that many of these PCR machinery is capable of detecting in making an informed decision. In fact, the IDSA has a recent publication on what antibiotics should be selected in the setting of certain resistant genes. However, with that being said, many of the guidelines here in the United States have not updated their guides in regard to how to use PCR. And that is because PCR is still considered relatively new, a relatively new modality of testing, that is, when it compared to the traditional cultures and stains. And many of these guidelines that have been published are over 10 years old. So we see change happening, but unfortunately it happens slowly. And these changes are happening also outside the United States. But we expect there to be changes in some of the current guidelines in the USA very soon.
Sure. I know in the US, we really function on guidelines as the gold standard, but changing clinical practice from the public health standpoint, it takes about 17 years given the literature. Marcus, how is P4 tackling the current utilizing the current literature and guidelines for their content selection, and what gaps do you see from the laboratory side?
Yeah, so when we look at content selection, we do a multi-dynamic approach to this. We look at the markers that we're running. We look at new and existing literature. We also compare it to different modalities. So when we're looking at our PCR assays, we're comparing what we see out of next-gen sequencing and what we see out of traditional culture and sensitivity. We actually just put forth a publication submitted that was over 40,000 patients, where we're looking at PCR to what the culture and sensitivity results are. And we're constantly adapting to really improve upon the panel as we go forward. We're actually on our 4th generation, to give you an example, UTI panel, and they're not massive changes, but we do tweak it. And it's one of the benefits of an LDT is the ability to tweak and optimize that over time so that you don't rest on your laurels and you're constantly advancing and improving the platform. That includes even, from a reporting standpoint, as Dr. Frenkel could tell you with Arcstone Medical, you look at constantly trying to make improvements to that. However, there are a couple gaps that are important from a regulatory standpoint, specifically with clinical utility and showing clinical utility studies that will ultimately impact what the reimbursement is going to be. I think we're fortunate right now that there's been a lot of physician adoption on this. And the one advantage that physician group practices that adopt this have that I don't have at P4 is that they have what the treatment was, they have what the outcome data was, and they've got the ability to publish on that. And so I think it's incumbent on all of us to continue to publish and put out what these findings are so that we can optimize the assays, optimize where they're used from a clinical standpoint, and that'll ultimately shape what the reimbursement landscape looks like long term.
Thank you both. It seems to be an ever-changing and evolving landscape, right? It seems that we're continuously moving, whether that's policy, but we really need to work together in this cycle of how is this clinically relevant, how is this clinically useful, and how is this affecting ultimately the patient, right? Not just working together. And over the last 2 to 3 years or so, the U.S. specific health policy has changed landscape and infectious disease, PCR panel testing, molecular diagnostics, things like that. And the implementation of such policies have required an adaptation for determining panel content, as we've discussed, right? So Marcus, can you discuss the process your laboratory takes to determine specifically the number of targets that are on the panels, and how has this evolved over the last maybe 2 years?
Well, and you clearly see this from a policy standpoint, that there's a movement towards what they call tier 1, 3 to 5 targets, tier 2, 6 to 11 targets, tier 3, that are 12 to 25 or more targets. And so typically speaking, whether that's a Medicare provider, whether that's commercial insurances, screening tools, they want to see down in that tier 1 category, whereas the broader applications for those chronic recurrent conditions qualify for a tier 2 or a tier 3. And those are more clearly defined with panels like respiratory and gastropathogen than they are with, a wound, with a UTI, with a fungal type panel. But they are something that, federal and commercial agencies look at and review. And so you try to figure out what is the best fit for each one of those. But great example of that, quite frankly, is we've gone through the pandemic, is a lot of labs going from COVID testing to COVID, flu A, flu B, maybe they add RSV in there. It doesn't have to go to those much larger syndromic panels unless it's something that becomes a chronic condition where we're clearly not answering the question that is needed or asked for, with a smaller panel size. Altogether different than if we go to something that is a recurrent event, second office visit in 6 months, third office visit in a year, where a larger panel is going to be required in order to effectively manage that. We see that with something like a UTI test, where even if we targeted the top 7 pathogens, we're only going to get about 72% diagnostic pickup rate. That's equivalent to what culture and sensitivity statistics have shown. So we're getting a faster result out, but we're not getting something that's more in-depth. We really need to get into that 17 to 24 target range in order to get to 90, 95% from a clinical sensitive standpoint.
It's interesting as we discuss number of targets, right? So where is it appropriate, and can that line be arbitrary? Is it, that we've tiered it and sectioned it and we as in the federal and state levels, right, and other commercial payers as well, but we've tiered it in a way that, are these lines arbitrary? Do they make sense? And Dr. Frenkel, how would you determine an appropriate number of targets to be on a panel?
So it's a good question, and I just want to add to what Marcus already said, that there's another layer to this, and that's the capacity of the machinery the labs are using to get these targets. Some are bound by more or less. So besides for the reimbursement side of the equation, their actual capacity based on the machinery also plays a role in how many genes or how many organisms they can test for. So that's something to consider. And when it comes to the number of different targets, when we're dealing with different types of diseases, that plays a role as well too, because depending on what we're looking to diagnose may vary on how many targets we want to put in that panel. So respiratory panels, if we're designing a panel to look just for viruses, and that would be one thing. But if you're looking for a panel to detect all pathogens that may be respiratory origin, then the panel will be much larger. And so that's important for the clinician to understand that these panels are bound and they could be specific to certain types of diseases, or they could be designed to be as general as possible. So that's very important information for a clinician to understand that because there are targets, just because you didn't detect it doesn't mean it's not present. And that's important information to internalize.
I like how you brought up the clinical perspective in that. And we do tend to focus on number of targets in the policy and reimbursement world that such that I'm in constantly, but we still need to ensure that the appropriate targets are placed on that panel. So whether that's, in that tier 1 or tier 2 or 3rd category for those patients. Our customers are struggling with increased scrutiny surrounding what pathogens are on those panels, and how can we dissect the panels in a way that meet those needs. Dr. Frenkel, how does the content selection and number of targets differ between diseases or maybe classes of disease?
So it depends, and again, that can be a very long, detailed response, because you can divide these panels into subpanels theoretically. For example, when it comes to respiratory infections, you may want to design a panel looking at just mycobacterium, just viruses, just bacteria, and then within the different classes of microbes, you can subcategorize it even further into atypical infections versus typical infections. So it depends on the lab's capabilities and how many panels they want to design. Unfortunately, what we see just in the field is that most laboratories don't have the luxury of creating in multiple different panels for their clients. They're trying to create a panel that's somewhat universal for that source, so this way it can be applied in an economic way. But because we're bound, because many laboratories are bound by the reimbursement, they're often restricted on how broad to make these panels. So they're always walking the line, trying to provide the most useful panel from a clinical perspective, that we want to detect what the physician is looking for, but at the same time to create overly diagnosing, but we're also not underdiagnosing, because we can't put too much on a panel for multiple reasons, like we mentioned before. So it's difficult, and it takes time to sort that out when labs are starting to design these panels.
Marcus, when P4 are starting to design their panels, how are you taking into account the balancing act between number of targets and the increased scrutiny we're seeing around the content selection? How are you differing? How are your number of targets differing between your disease states or classes?
Yeah, so on things like respiratory, we tend to have a lower number of targets, moderate number of targets when it comes to gastropathogen, and a larger number of targets with UTI. But again, those are different populations that we're looking at. On the respiratory and on the gastropathogen, those are really upfront screening type tools with somebody who's symptomatic. On UTI, we're only really using that product in a chronic recurrent state. But one of the things that Dr. Frenkel brought up that I think is very important is how you run the test gives you different capabilities or limitations. So if you're using spotted 96 or 384 well plates, that's different than if you're using an array technology, where maybe you can have a more diverse subset of targets, and then bioinformatically masks those where it may not be appropriate, or the test may not be ordered, but it gives you the bandwidth to be able to run more targets. And one of the nice things I can say overall, we've seen this from the pandemic, we've seen this from some of the technology that Thermo's made available, is the cost to run these tests is coming down, especially on the LDT side versus the FDA labeled side. So there is the capability of being very cost effective with running these in a larger spectrum, but making sure that we're not doing so simply for a billing standpoint. It's really for the diagnostic and medical efficacy of what we're running.
That's great. I'm glad to see that we're walking that line between what's going on, both the balancing act for content selection and number of targets versus the actual number of panels. From the epidemiological perspective, public health officials want to see how disease is spread through the population, and it is inherent to the overall epidemiological thought process. So as the SARS-CoV-2 pandemic really took place, Dr. Frenkel, you've discussed how now labs are starting to uptake both COVID-19 testing, flu testing, flu A/B, and RSV testing. The epidemiology really became a household topic during the pandemic with how the diseases are spreading through the populations and, contact tracing and all the buzzwords that we remember hearing throughout that time. And while we do tend to discuss our patient-specific care, public health and populations may also need to be taken into consideration when we're synthesizing a panel. Marcus, how is P4 taking into account patient populations for the use of panels and how this is impacting your content selection for those panels?
Yeah, it's a good question and something that we're constantly under review on. You want to look not only at the panel that you're addressing, but also what's the subpopulation that you're addressing. So give a couple of explicit points here, but we talked about UTI, so I'll talk about it one more time. But you've got targets like a group A strep, and I've had multiple PhDs in microbiology tell us how important group A strep is in UTI. Well, the truth about it, it's important in the pediatric subpopulation of that. You're not going to see that in a healthy adult. So if you're in a healthy adult, you really don't need group A strep as part of your panel. So that could be something that is either an add-on or, as discussed earlier, maybe you bioinformatically mask that and reveal that when you have a pediatric patient that comes in. On the opposite end of that, you've got people that are geriatric in nature. And so you occasionally will see gastropathogen targets in a UTI case. Those include Bacteroides fragilis, Salmonella, Campylobacter. Really what that is that's a causative event because you're in adult diapers. And that's something that we're seeing is, whether it's a nursing home or somebody that has had a prostatic procedure and they're in a diaper, those start in the gastropathogen, move up into the urinary tract. And so those targets might be, again, applicable for somebody who's in that state, but it's not going to be applicable for a healthy person that is in the middle of their life. And so we look at that and either have add-ons to those panels, or we bioinformatically mask and don't report those out so that we're really not overdoing it from a test, the whole spectrum if needed on a specific patient.
It seems that, P4 is doing a great job at masking those targets and really determining what's appropriate for those patient populations to be tested in, rather than overdoing it and billing just for billing purposes. So that's amazing. But Dr. Frenkel, how, with your background in both infectious disease and public health, how would you consider taking patient populations into account for panel composition?
So I want to touch upon some of the things that Marcus spoke about and add as well to that. The patient population is actually very important because of many of the things that Marcus mentioned. When we're looking at microbes, some microbes naturally exist in certain patient populations. He mentioned pediatrics, group A strep, very important pathogen. Certain microbes we'll see in the elderly population, we might consider colonizers or contaminants, but when we see in other settings, it's something we need to take seriously. And because PCR and molecular in general is so specific and so sensitive, we're going to pick up these microbes across the board. So laboratories and clinicians need to understand how to interpret these results when they come back to the laboratory. And that's part of what we do at Arkstone, is we provide that interpretation so that there's no overtreatment, or we don't ignore an organism that actually matters in a certain situation. So molecular, fortunately, is being used across the board. We're seeing it in pediatrics all the way up to long-term care and rehab, nursing homes, urologists, gynecologists, pulmonologists, wound care physicians, and so on. So when they add molecular to their toolbox, now they have more capabilities. They're able to do things they weren't able to do before. It opens a whole new world for rapid diagnostics for them, but it comes with a bigger responsibility in understanding how to use this tool as well, because it's new and it could be misinterpreted. So the population matters. And going back to what we discussed before, labs don't have really the luxury, from just my experience being in contact with so many laboratories, of creating these panels specific to the population. So they're struggling with that line again of how do we design a panel that we could market, so to speak, to a doctor who does geriatrics and a doctor who does pediatrics with not so much variation in the panel. Because what ends up happening is it becomes costly to design different panels for different populations. But under ideal circumstances, that's what you ought to do. I would imagine you would have a panel not just specific to the population, but even to the syndromes you're looking for. And hopefully, as we see molecular expand and the data trickle in on how useful it is, there will be an opportunity for laboratories to develop this, and it makes sense for them economically as well.
I like the reference that you added to the toolkit that labs should have, right? And the toolkit for the addition for these differing panels between the populations of people, or the toolkit maybe in referencing antimicrobial resistance markers. It's something that I know I've gotten a lot of questions about, and I would love the take of both of you as the experts for the antimicrobial resistance markers that we are utilizing on PCR panels. And they've been a prominent conversation piece because policy's really not outlined the antimicrobial resistance to the extent that it has the pathogens. So we have these boundaries around our pathogen targets, but now we need to understand how is AMR relevant antimicrobial resistance. And Dr. Frenkel, can you comment on maybe the benefits and barriers of antimicrobial resistant gene detection? Specifically, can you speak to the sensitivity versus resistance?
Yeah, absolutely. And this is a very common question and a very common source of confusion. When we talk about toolbox, I like to use that analogy because I think of a hammer and a drill as serving similar purposes, but not exactly the same, and sometimes not interchangeable. And that's how I see sensitivities and when it comes to resistant genes. They may be similar in many ways because they tell us about whether something is resistance, but they're not telling us exactly the same thing. And a lot of it's not interchangeable. So resistant gene information is very valuable. And for most people who don't understand, it's when a PCR, using PCR to detect whether or not a microbe is harboring a gene that can tell you valuable information as to whether or not the microbe may cause resistance. But it can't tell us with certainty which microbe at this point. When we do resistant gene testing, we're doing it in the whole sample. So we may detect 5 microbes and 1 resistant gene. We're able to make correlations, which gene is likely expressing it, which organism is likely expressing it, but we're not able to say with certainty. And furthermore, even if a gene is detected, it doesn't mean that that antibiotic will necessarily fail with certainty. In addition, the gene that was detected doesn't necessarily mean that there are other mechanisms of resistance that may not be present, meaning if you detected no resistant genes, it doesn't mean that that antibiotic will still work. There could be other reasons why the antibiotic may fail. So there are clear limitations on resistant data. And there are lots of things that we know can cause resistance that may not be detected through genotypic analysis. But with that being said, there are also weaknesses to sensitivities. And a lot of new emerging data shows the phenomenon of heteroresistance, which is described in literature. It's a phenomenon where pre-existing subpopulations of resistant microbes can be selected by an antibiotic, meaning you have sensitivities that say everything is sensitive, and that's because the majority of the growth of the microbe is showing that everything's sensitive. But once an antibiotic is introduced, it basically selects a subpopulation of the microbe that is resistant, and subsequently the patient ends up failing antibiotic therapy. So that cannot be detected through sensitivities, but resistant gene information could give us insight to whether or not a subpopulation is expressing resistance. And lastly, inducible resistance, which is another pitfall of cultures, is when a resistant gene is present, but it's not being expressed unless the antibiotic is in its presence, like AMP-C. So for example, you get a urine culture that comes back. It says everything's sensitive. You put the patient on ampicillin, but 48 hours later, the patient fails. And that's because the microbe was harboring an AMP-C resistant gene. and that caused the resistance. So to sum it up, there are both weaknesses to both technologies, then there are both benefits and advantages. So in the best scenario is having both these tools available. And that's why I say a toolbox, because the clinician should have these tools available in one area in their practice so that they know when to use these, and sometimes may want to use them together. So this way they can account for the weaknesses and strengths of both these tests.
That's a lot of information to digest and extremely well detailed. And Marcus, I'm interested to see how we can take the theoretical aspect that Dr. Frenkel has just spoken about with the sensitivity or benefits and barriers of the AMR and transition it to practically how is your lab dealing with those benefits, barriers of detection of AMR genes?
Yeah, so it's something, and I really appreciate Dr. Frenkel's commentary on this, and I think he's spot on. Quite frankly, we have seen the strengths and the limitations of all these different technologies. And so one of the things that we've done from the onset at P4 is we have run culture and sensitivity alongside our microbiology. We understand that one of the real big benefits of PCR and molecular testing is the speed and the turnaround time of that. And so we feed that information to clinicians as it's available, but we also understand that there's a lot to be done about the microbiology susceptibility testing and the resistance markers as well. And so we run both of those in comparison. Give you an idea, when we run other technologies like next-gen sequencing, we will hit up against the what's called the CARD database, which is the Comprehensive Antibiotic Resistance Database. And to give you a spectrum of how many different gene resistance markers are within that database, I think in 2022 they had over 2,800, and I believe today it has over 3,000 different resistance markers. So in any of our PCR assays, we're only taking a handful of those resistance genes and being able to display them for the clinicians ultimately. Now we're trying to obviously curate and select the most common ones targeted to the pathogens that we're testing for so that they're more relevant in terms of overall scope. But it is important that we do get that susceptibility and that resistance data from microbiology to complement all this. And as we all advance forward, and we're really at the forefront of a lot of this, it's important to have from a comparative standpoint too, so that we can see what the actual impact is as we look to further curate these assays going forward.
It's very interesting that we discuss, Marcus, it seems that we're making very data-driven decisions based on where to utilize the AMR genes and maybe how you guys are utilizing them within your within P4 diagnostics. A few minutes ago, we had a discussion around the scientific literature and medical guidelines. And Dr. Frenkel, you had discussed in the answer to our last question, there's some limitations to that data. But what is the current role of AMR in healthcare and the treatment guidelines?
So that's a good question. And as you all know on the call here, antimicrobial resistance is becoming a more central conversation. And it's really the focus of what we're doing at Arkstone, and the focus of my career is really antimicrobial resistance. It's the silent pandemic, and it's getting worse and worse. And you're going to see more public health officials speaking about this as we try to bring more attention to this. And it's COVID-19, in fact, has exacerbated antimicrobial resistance in many ways. In many ways, it's shifted focus away from it. In a technical aspect, it worsened it. A lot of antibiotics were being prescribed for respiratory infections, and a lot of literature demonstrates that antimicrobial resistance has worsened over that period of time. And many studies and governing bodies predict that antimicrobial resistance will be a leading cause of death in the future. Some studies already show that antimicrobial resistance causes more death than HIV or malaria, which is really a staggering statistic. Therefore, antimicrobial resistance is critical in healthcare. It's going to affect our rates of hospital-acquired infections and admissions, and whether or not these infections are even treatable. Post-surgical complications are going to be affected by this and pretty much across the board. And if you really want to be realistic and get down to earth here, every person will have some sort of infection. You can almost say with certainty that throughout a person's life, there will be an infection that you will have, whether it's a cut on the finger or it is a GI infection. And although we take for granted at this point in our lives, at this point in time, that these things are easily treatable, we have an open mind and understand that based on what we're seeing right now and the data coming in, we shouldn't take this for granted. And we fear in the future that even the simplest infection will be impossible to treat, or could potentially be impossible to treat due to antimicrobial resistance. So the short of the answer is that guidelines are changing to accommodate what we're seeing with antimicrobial resistance. There's lots of talk. And again, I think we're still at the beginning of a shift in the current guidelines. But we're going to see, the prediction is that we're going to see this incorporated more into routine guidelines that physicians will rely on, hopefully make better decisions.
Thank you. I think it's becoming increasingly more and more important as we look at antibiotic resistance, antimicrobial resistance over the last even 10 years, right? We're seeing it increase. Marcus, what's the role of AMR detection for P4, and how are you guys how are you utilizing the treatment guidelines?
Yeah, so a couple of different pieces to that, and reiterate the fact that the antimicrobial, the stewardship is a really important part of it. I saw a study the other day that by 2035 there'll be more deaths due to bacteria than by viruses, which is kind of a scary thought. We're getting better post-pandemic with managing viruses, but we're getting much worse at treating bacterial infections, and part of that probably is pandemic induced, as you were talking about, Dr. Frenkel, with telehealth and the ability to overprescribe and just empirically prescribe antibiotics. And we need to get away from that. We need to move towards a point where we are testing and treating a pathogen with known data and known content. And so, give an example of that. If you look at E. coli infections and UTI, first-time infections, there's studies that show 76 to 80% of those are caused by E. coli. But if you have a chronic recurrent condition, so second visit 6 months, third visit in a year, our statistical data that we just published shows that that number drops to 47 to 48%. But of that, only 26% are E. coli alone. 21% of those polymicrobial. Very oftentimes you might get something like a ureaplasma or a mycoplasma that's along with that. And so where that's important is that actually does change the potential treatment that you might give. If you were to look at Johns Hopkins or Sanford routine treatment guidelines, you'd be looking at like a trimethoprim, you might be looking at a ciprofloxacin. But if you had that polymicrobial event, levofloxacin is going to be a better treatment alternative to that. It's of course notwithstanding allergies and all these other considerations that are, the physicians have to consider when making a final treatment decision to those. But it is very important that we be able to identify those polymicrobial events in these complex recurrent cases, because otherwise we're going through 3, 4, 5 doses of antibiotic before the patient gets treated. And as you have these polymicrobial infections, they're passing these gene resistance through plasmids in a process called transduction, and that really exacerbates and proliferates these antibiotic resistant rates that we've seen. We had a case back in 2018 when we were early on in this, where we actually saw it was a Klebsiella case, and all 18 gene resistance that we had kind of lit up for Klebsiella. And so fortunately it grew out. And we ran it on 2 different microbiology platforms, and it showed resistance to every pathogen that our Vitek and our microscan units showed. Our microbiology team wound up plating it out, found something that at a very high level might work, but it shows you just how aggressive, and that was the worst case we had seen to that point in 18 years as a clinical laboratory. And so a problem that is worsening, and better detection so that we're treating based off evidence and not empirically is really what we all are trying to achieve here.
I think the case study that you just brought up was great. It's, if a patient needs treated with 5 different types of antibiotics, how does that impact their overall quality of life and ultimately for policy, what in the payers, what does that do to their overall healthcare utilization? So we're both impacting the quality of life of these patients by treating them faster and getting them back to their normal selves faster, but also the healthcare utilization aspect, and that goes to quality of life as well, getting them out of the hospital, out of those visits, and that utilization benefiting the patients all over, which makes antimicrobial resistance seem very important for the treatment of these patients. So we don't know, however, when do we actually know that they're appropriate to add to the panel? Dr. Frenkel, would you take that question?
Sure, sure. And it's actually a complex question to answer because it actually depends on the source of the specimen and what microbes are being tested for. So it really depends on the microbe side of it. So when you're testing for just the viral pathogens in a respiratory specimen, where antibiotics are unlikely needed in the first place, testing for resistant genes may not matter in that scenario. But if you're testing for wounds or urinary tract infections or respiratory infections that may have bacterial etiologies, then you want to make sure you include resistant genes because that's a method of tailoring antibiotics appropriately. So really, it depends on what you're testing for on the microbe side so that you know what genes to look for that are parallel to that. And that comes back to what we spoke about before, designing the panel. So you almost want to design the panel backwards in a way, where you're looking, okay, what are we trying to diagnose? What are the most common microbes? What are the most common associated resistance to those microbes? And work your way from that side of the equation. That is how we find it's best to determine what to even put on these panels.
Yeah, I think, it's very complex, definitely with the different classes of disease and the decision making there lies ultimately both at a physician level, but Marcus, it also lies at the laboratory level when you're predetermining the menu offerings and tests. So how is P4 diagnostics? When do they know when it's appropriate to add AMR to the panels?
Yeah, so typically it's when they would be of value and benefit to be part of that toolbox to the clinician. So as I think Dr. Frenkel very aptly hit up, we've got viral only, may not make sense to actually include those because we're not going to consider antibiotics in the treatment there. But if we've got bacterial and fungal targets, I do think it makes a tremendous amount of sense. And those are the ones that we pair up with those cultures. I'll point out to the earlier point about treating correctly and just share a quick story related to your last comments on some of this, Rebecca. Is, I had a family member in December that was symptomatic and they tested negative for COVID, flu A, flu B. And so presumptively they thought that this family member had RSV, but then prescribed antibiotics. And that's exactly what we have to get away from. If, we needed to confirm that they had RSV, and if you have RSV, there's no point to prescribing antibiotics. Otherwise, we're just giving out more antibiotics. And outside of the stewardship issues, it causes major issues with people's health. So their gut biome gets thrown out of whack. There's a lot of subsequent cost to the healthcare system downstream. And so we really want to be really judicious with how we're testing. And there's an example where we needed one extra target in a panel to make it more effective clinically. And if not available in that first line, probably should have been an add-on that was available before something got prescribed.
I completely agree with the antibiotic stewardship programs that are currently ongoing throughout the U.S. healthcare system to try to combat some of this overprescription. But it seems that we have tools in this toolbox to make a start to identify these organisms that may or may not be resistant and treat our patients a little bit better. I would like to take this time to thank both of you for your participation in this webinar. You've done such an amazing job with this discussion. It's been a pleasure talking with both of you. And I think if we're all agreeable now, we have a few audience questions to discuss that between the three of us, I think we have an opportunity to answer. I think a great place to start, if I assume we're all agreeable. Perfect. I see nodding heads. Where should I go to look for guidance on which bacteria and which viruses I should add to my panel? Marcus, let's start with you.
Yeah, so I think that there's good literature that is out there that you can look at. You've got FDA labeled assays in specific areas that you could use as a starting point for any custom panel that you're going to make. And then don't rely just on where you start. You want to constantly look. There's emerging pathogens that will come out. You may find that you have a specific geographic area where certain pathogens are more frequent. So where you may not have thought to include them in the first panel, they may be needed to be included, or you may want to drop something off. There's also more gene-resistant markers that become available. So I think it's constantly, taking a look at lead to where to start, but then looking at new literature and existing literature, looking at different testing modalities, like I talked about before, looking at microbiology results, looking at next-gen sequencing results. And then from a lab standpoint, I always think it's really important to speak with our physicians. What's their experience been with it? What do they need? Key opinion leaders in the area, and constantly working and kind of not resting, in terms of improving the assay as you go forward.
I like what you're talking about geographically, right? Because sometimes I think we forget how large the United States really is and how different spatial aspects can come into play with the geographic dynamics that we have within the spread of the diseases. I think there's statistics that during pandemics, it's easier. London is closer to New York based on flight travel than it is to, somewhere else in the US. So geographically and locomotion, things like that have really had this impact. Dr. Frenkel, where would you look anywhere else when you're designing when you were designing panels for bacteria, viruses, when you're thinking about starting the panel?
Yeah, well, first of all, we provide consulting at Arcstone for those labs who work with us, and even those labs who don't, on the best way to design these panels. And it's often very confusing. A lot of labs are starting from in the middle. They're looking at their peers. They're not sure where to begin. And we do see some really interesting panels that are out there that don't have good clinical utility, so to speak. They don't make sense for the setting that they're trying to use it for. I would also suggest that the CDC and the IDSA do have some guidance on the application of PCRs in certain settings. And with that, it's very important to use the best available evidence. You want to always make sure that you're on the side of the evidence, that it's evidence-based recommendations that you're giving to your clinicians, because at the end of the day, they're going to try to use this information to help them with a patient. So ultimately, we try to use the best evidence available, and it's evolving. It's also a moving target. The evidence changes. In other words, we learn more and more about these resistant genes and what the implications are. And of course, these resistant genes sometimes get worse over time. So they may mean one thing today, and tomorrow they mean something else. So it's a complex matter. So I would suggest that laboratories interested in going down this road definitely seek guidance from professionals and experts in this area to get it right out of the gates.
Perfect. And the next question goes back to the clinical utility that you had just discussed, Dr. Frenkel. Can you comment on clinical utility evidence generation and how long that process can take? I know my personal journey with evidence generation is long and drawn out. It takes about 6 months just to publish a paper from, manuscript submission to it actually being published in a peer-reviewed content, let alone the time for that data collection. Personally, it has been, I will always argue for retrospective data resources and real-world data evidence just based on my background. But data collection prospectively for some of these more novel diagnostics will take so much more time. If we have panels that have very novel pathogens on them, just prospectively collecting them will take years if they're not prevalent within our populations. So tying in what we've talked about with how frequently and what's the incidence rate of these diagnoses, things like that. Do we have any commentary from either of you two on, or Dr. Frenkel, would you like to start with the longevity of evidence generation?
Sure, and I agree with everything you just said. It takes a long time to go from data to publication from start to finish. In fact, we have a study that we are starting, and the estimated time for that was 18 months. And that's if everything goes well. So it's a long process. We know there's a lot of ongoing studies. Marcus had mentioned many of the exciting studies he's doing, and they have advantages of being able to compare cultures with molecular data. So I'm very excited to even see those results when they're ready. Marcus, you'll let me know, I'm sure. So there's a lot of evidence and data emerging. And the evidence could be specific to certain scenarios. Like, for example, some of the strongest evidence has to do with sepsis or in the setting of STDs. But that may not be, you may not be able to apply that evidence to, that's something outside of that specific scenario. So it's really important that studies come out that can generalize how to use a lot of this information. So it'll take time to update the guidelines and incorporate molecular into the current standard of care. The CDC does note that in many cases, as it stands right now, PCR is the standard of care in many situations, like, for example, detecting pathogens in meningitis. The CDC is obviously on board with molecular being the gold standard for many situations. And STDs, of course, and HIV, of course, we know molecular has been the gold standard since the very beginning. But this process is, again, it's ongoing. It takes a long time. And we're hoping that there are ways to expedite this so we can have this available. There's a discussion in general in medicine that if it takes so long to turn the ship, what about the patients in the meantime? Should we exclude them from the ability of getting access to some of the newer technology because we're not there yet with the studies? And then the flip side is, can we go forward without having the formal process of peer review and the data being checked by multiple different sources to make sure that it's accurate? So it's ongoing and complex, and unfortunately takes a long time.
Yeah, I think evidence generation, and I always discuss the traditional research definition as we move through these conversations of how do we generate this evidence. And Marcus, it seems that you're all doing some studies that may be that traditional research where we're looking at those patients and comparative studies. Would you care to comment on the longevity of those studies?
I mean, the data that we're looking at, it's taken several years, quite frankly, to capture. So, in some cases, I think we're going back to 2020. So we're looking at 2-3 years to capture that, writing the paper, going through the publication process. But I think it's important that labs, one criticism maybe of the lab industry is to more proactively publish and work with physicians to publish what those outcome data are, because cumulatively we can cut down on some of the times if more labs were to get good, well-written publications that are out there that speak to the utility of this. Quite often we get an emerging technology, everybody rushes to utilize the testing, but we don't do the hard lifting and the heavy lifting of going back and doing publications so that information is out there, so to help influence and shape the guidelines going forward, and so that we can figure out how to optimize different aspects as we go forward. So I think there's an opportunity. It's the reason we've really at P4 enjoyed working with our physician partners on this, because they have a lot of that outcome data, and it gives us a much faster capability of publishing more meaningful data, looking across multiple diagnostic specialties, but then also looking at what those outcome data look like.
I think all three of us have just agreed that it is a lengthy and long process. The next question for the audience, I think we have about time for 2 more. If we were to tie together the target list and target patient population, is it better to take a broad approach? Dr. Frenkel, would you possibly maybe elaborate on the use of broad target panels?
Yeah, and the simple answer to the question is it depends. What source are we targeting? Like we mentioned before, are we concerned about certain types of infections in that particular setting? In other words, for most cases, a one-size-fits-all may work, but physicians and clinicians have to be aware that medicine, of course, is not a one-size-fits-all model, and in the same situation, when it comes to this, it's the same idea. So we may have a different set of organisms that we're concerned about in a pediatric population versus geriatric, like we mentioned above. The harder part of this conversation is that most labs don't have the luxury of designing these specific panels for specific situations. Therefore, a broad approach is sometimes the most practical approach. I think that's where laboratories, again, are walking that line. How do we create the most usable panel that's going to hit the most common organisms? But clinicians need to take into consideration that, again, it is a broad panel. So it may not be specific to what they need for that scenario, and they always have to keep an open mind to that.
Marcus, would you be able to discuss the laboratory considerations with the broad panel approach, or what your approach currently is?
Yeah, so it depends. We've got smaller panels and we've got larger panels, and it really depends on what the clinical use of that is, either the disease state or specifically, what the target population is on it. So it is a complex question. A lot of times, what we're left with is looking at larger panels, but understanding that they're not going to be reimbursed because of the current policy decisions, that they're going to be reimbursed at a lower level. And so there's always that cost consideration that we need to look at from an efficacy, financial efficacy standpoint as a laboratory of, if we're getting reimbursed in the 3 to 5 or 5 to 11 target range, can we afford to have a larger panel, understanding that the reimbursement is lower? That's where, too, we've looked at things like, if you have pathogens that you can pool so that you're putting multiple targets, and not differentiating and reporting them out at a speciated level, sometimes that can bring down the overall cost or increase what your throughput is. You're still providing, the same level, or in some cases an increased level, because you're putting more targets on there from an efficacy standpoint, but it makes more sense financially on a go-forward basis. But it is very complex, disease state and patient population related, and you've got to consider all that when you're looking at this.
Thank you. I think we have time for one more question. So the question is, when combining culture, susceptibility, and PCR results, should I wait to send one report, or can I leverage the speed of PCR for preliminary results? Any advice on how to communicate the AMR gene results ahead of final susceptibility results? Marcus, I think I'm going to let you take this one.
Yeah, absolutely. And I think it's a great question. So our approach at P4, as I've stated, we run the molecular results and we run the culture and sensitivity results. And I would tell you, when we first launched with this, we waited till this culture and sensitivity results were out, and we did not find, in feedback from our physicians, that was particularly helpful. Two of the huge benefits to PCR testing, yes, increased sensitivity, increased polymicrobial detection, that's all true, but also the speed of the test, being able to get a result out within 4 to 6 hours versus waiting 48 to 72, or in some cases longer, on culture and sensitivity. And what we're really trying to do is give the clinicians information as quickly as we can so that they are going to make an informed decision on treatment. So we had a great seminar with 2 of our urogynecologists the other day, and they consider aspects of how much pain is the patient in, what day of the week is it in, are they going to go into the weekend? So if we can give them results that are actionable sooner, that gives them more information to treat versus just treating empirically based off of pain or symptoms, and that wanting to make sure and mitigate an opportunity for a patient to go into an urgent care clinic or an emergency room over the weekend. So we do publish, because of that, the gene resistance guidelines that we get. There's an important physician education piece to this, of making sure that those are not an absolute, but they are a tool that can help guide the treatment decision. So let's say you've got a pathogen and you've got a gene resistance to that pathogen, say for fluoroquinolone. Well, stay away from, consider not giving Cipro. It doesn't mean that the drug that you give is definitely going to work from a susceptibility standpoint. It also does not mean that the patient might actually have some susceptibility to Cipro because maybe that gene, wasn't expressed, so or what was downregulated. And so there's considerations to all this. It's not an absolute, but we do think it's very important. The speed benefit of molecular is critical, and getting that information to the physician so that they can use that as part of their toolbox to treat is important in doing that.
Dr. Frenkel, from a medical perspective with the antimicrobial resistant gene results, would it be better to know before, or would you prefer as a physician to have them combined?
So I want to second what Marcus said. He said it very well. And I think there's a value to having the PCR as a preliminary report for immediate action. And we see lots of data as it pertains to this method in settings of bacteremia and sepsis, where a patient comes into the hospital unresponsive and in septic shock, and PCR can give the results back within an hour or 2 hours. And this way you can tailor antibiotics with those results and give the patient the best shot of surviving until cultures come back. And then when cultures come back, you can use the data collectively. We have a combined report at Arkstone where we take the molecular data and we take the culture data and we put it all into one singular report. So if the clinician knows how to use that information. There may be discrepancies. There may, like Marcus said, there may be a scenario where it may be sensitive to a fluoroquinolone, but a resistant gene is detected. And of course, in that situation, we would say avoid just in case. We want to always use the precautionary principle when it comes to these scenarios. But certainly PCR has a role in being a preliminary report in these settings for the rapid result, the accuracy of PCR. And so, and in the most ideal situation, and I'm glad to hear Marcus is doing this, the cultures confirm the findings, or perhaps give you more information so you switch gears at some point to make sure that you don't miss anything. So, so yes, there is value in providing that, and hopefully more clinicians see that, and more laboratories jump on that, because there's definitely a clinical value here in providing both these technologies simultaneously.
With that, thank you. I want to take the time to thank both of you for participating in this discussion. I know that I've learned an exponential amount more about panel content, also have a lot more information in this toolbox, as we've said multiple times, that we can utilize to really make sure we're choosing the right panel contents and targets. And so thank you both so much. So thank you again to Dr. Frenkel of Arkstone Medical Solutions and Marcus Cognetti of P4 Diagnostics for your time today and your such important research. We would also like to thank LabRoots for helping us with this webinar, and our sponsor, Thermo Fisher Scientific, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today, and those submitted during the on-demand period, will be addressed by the speakers via the contact information provided at the time of registration. This webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. And until next time, take care, everyone, and thank you.